Today, we're shifting our focus from the acute crisis to the critical, ongoing management of one of the world's most pervasive chronic conditions, chronic kidney disease, or CKD. The evidence is clear. Nutritional strategies are a core pillar of care. Joining us to break down the latest clinical approaches is Dr. Emily Wang. Dr. Wang, thank you for being here.
Thank you, James. It's a vital discussion for all healthcare providers.
Let's start with the big picture. For our audience of healthcare providers, why is a meticulous focus on nutrition management so fundamentally important in the care of patients with CKD?
It's crucial because it's a powerful, modifiable lever we have to influence the disease course. Targeted dietary interventions are essential to help slow CKD progression, manage complications like hypertension and metabolic acidosis, and control the accumulation of uremic waste products. Without proper nutrition management, we accelerate the decline of renal function and dramatically increase morbidity.
That brings us directly to protein intake, which is often the most controversial and challenging aspect for patients. What are the current evidence-based recommendations for protein targets in non-dialysis CKD patients, and what are the major risks associated with deviating from those guidelines?
The recommended target protein intake for non-dialysis CKD is relatively restrictive, 0.6 to 0.8 grams per kilogram per day. The evidence shows that high protein intake accelerates renal decline, worsens albuminuria, and elevates cardiovascular risk. However, we must be equally vigilant against the opposite risk, malnutrition. Very low protein intake, especially if unsupervised, can lead to severe undernutrition and higher morbidity. Therefore, regular dietary counseling and nutritional assessment are non-negotiable to ensure that patients maintain adequate calorie and nutritional intake while restricting protein.
Within that protein restriction, the quality of the protein source is increasingly emphasized. Could you elaborate on the shift towards plant-based proteins and the physiological benefits they offer to the CKD patient?
Absolutely. We are increasingly favoring plant-based proteins, ideally in a moderate plant-to-animal ratio. The benefit is twofold. First, plant proteins are generally associated with the lower phosphorus load and a lower acid load, which directly reduces the metabolic burden on the already compromised kidneys. Second, plant-based diets help decrease the production of uremic toxins and limit the progression of kidney injury. It's important to note, however, that an exclusively plant-based diet needs careful planning to ensure essential amino acids and micronutrients aren't missed. We explicitly advise limiting red and processed meats, as they are strongly linked to faster CKD progression.
Let's move to electrolytes, specifically phosphorus and potassium. What's the clinical strategy for managing these, and how do their dietary restrictions evolve as CKD progresses?
Phosphorus restriction becomes critically important as CKD advances and renal function declines, and dietary adjustments must closely mirror the patient's serum levels. Excess phosphorus significantly worsens secondary parathyroidism, contributes to vascular calcification, and drives kidney injury. Similarly, potassium intake must be highly individualized based on serum levels and the patient's risk for hyperkalemia. An important practical distinction is that potassium from plant sources is typically less readily absorbed than that from animal sources, which often makes plant-rich diets generally safer in this context.
And what about sodium? What's the key target for our providers to communicate to patients?
Sodium intake needs to be aggressively limited to less than 2 grams per day. This restriction is paramount for controlling hypertension and managing fluid overload, which are major drivers of CKD progression. Reducing sodium lowers blood pressure, reduces the risk of edema, and slows the rate of renal decline.
We've seen a lot of emerging research on the gut-kidney axis. Can you connect that to the role of dietary fiber in CKD management?
This is a rapidly growing area. High-fiber diets are incredibly beneficial because they improve gut microbiota health and, critically, decrease the formation of uremic toxins. By modulating the gut microbiome, increased fiber helps control systemic inflammation and supports overall metabolic stability. In fact, research shows that each additional 5 grams per day of fiber is associated with better cardiovascular outcomes and reduced all-cause mortality in CKD patients.
Given all these interconnected factors, what are the take-home practical messages for our audience of frontline healthcare providers?
The most important message is that nutrition is a modifiable risk factor. We need to embrace a strategy that is individualized, plant-focused, low protein, and low sodium. Routine nutritional assessments should be done at least biannually. Most importantly, collaboration with a registered dietitian is absolutely essential. They are the experts who ensure optimal dietary planning and execution. We must consistently monitor key labs, electrolytes, nutritional markers, and adjust the patient's nutritional regime based on their current clinical status. Diets like the Mediterranean and appropriately modified vegetarian patterns have proven benefits for lipid management and acid reduction.
Dr. Emily Wang, this has been an incredibly insightful and practical breakdown of nutritional strategies in CKD. Your emphasis on individualized, plant-focused care is a powerful takeaway for all our listeners. Thank you for sharing your expertise on emergency insights.
My pleasure, James.